Okay, sounds good. So thank you everybody for joining. My name is Cynthia Coe. I'm the Associate Chair for Faculty Affairs for the department and stepping in for Conrad and our Chief Residents today. It's my great pleasure to introduce Dr. Tomas Mustelin as our grand round speaker today. Dr. Mustelin is the current division head for the Division of Rheumatology. He received his MD and PhD degrees from the University of Helsinki in Finland and began his early career in Finland before coming to the United States in 1992 to join the La Jolla Institute for Allergy and Immunology. Spent several productive years in San Diego, but in 2007 migrated to industry, serving in several different roles for development and discovery of novel therapeutics, especially for rheumatologic diseases. We were fortunate to recruit him back to the UW in 2018 as a professor of medicine. He became the interim chief for the division in 2021 and then the permanent division head for rheumatology in 2022. He maintains an active NIH-supported investigation program for pathogenic mechanisms of autoimmune diseases. And I'm really excited to hear what you have to say today. As a reminder to all the participants, please put any questions that you have in the chat and we will address them at the end. Thank you.
Okay, thank you, Cynthia, for a very nice introduction. So let me first explain the title of my presentation. So I was ruminating over what to present to all of you today. And I first thought perhaps I need to give a bit of a progress report of my years as a division head and tell you what we've done to build rheumatology. And I started thinking that probably isn't super exciting for a larger audience. So I then contemplated whether I should talk about what we do in rheumatology and the different aspects of how we serve our patients. And I thought still that wasn't quite enough, so I contemplated a third title to pick some examples from our research, and here's some catchy words to describe it. So in the end, I decided I'm probably going to have to do all three. So about a third of my talk will be in each of these categories. And here's just my mandatory disclosure slide. And so I'm going to begin by giving you sort of hard evidence of the Division of Rheumatology. This is our faculty. We are soon 43 faculty members, and of course we have administrative and staff of many kind as well. And I'm quite proud of that because we were smaller than this earlier. And particularly after the pandemic, we lost quite a bit of faculty for a number of reasons. And it's been a goal of ours to recruit back and fill up the clinics and our laboratories with faculty to be sort of up to speed and fully productive and be able to share many of the duties in a much more reasonable manner. So, and I'm not telling you this to brag, just to give a report of what we have done. So we are essentially at a place now where our clinics are fully staffed, realizing at the same time that there's a lot of patients out there that would need us, and we are not at a volume where we can serve all the patients that we could. But we have used all the space that we have in the clinic, and future growth would be dependent also on getting more space and all the infrastructure that goes around that. So timing-wise, pretty good right now. So we have gone through some big changes, I would say. So here's just a snapshot of what the division looked like before the pandemic. This looks like a picture from the 1970s, but in fact it's just 7 or 8 years ago. And here's a snapshot of what we suffered through the pandemic with working remotely and so forth, with all the advantages and disadvantages that brought. And here's how we look today. I think you see a lot of smiling faces and relief. We feel like we have largely recovered from the pandemic and rebuilt a great team spirit and a good atmosphere in the division. So let me talk briefly about what we do, and I often start with the university's overall mission and tagline, learning, discovery, and public service, to give our version, which is education, research, and clinical service. So these are the three fundamental and I think co-equal pillars of how we view our mission in the division of rheumatology. So viewing it as a separate pillars is probably not really accurate in my view. I like this Venn diagram better because it illustrates how much the three main functions that we have overlap and synergize with each other. So for example, education and clinical service is enormously overlapping. We use patient service as a educational tool, particularly for our fellows, also internal medicine residents and medical students and so forth. And having the fellows in the clinic is enormously valuable for keeping all of us sharp and serving our patients much better. So absolutely a two-way street. The same is true for our clinical service and our research. Our research is very much fueled by questions that come up in the clinic and patients that we see, the diseases we work with, and we very largely depend on patient samples for much of our research, either physical samples or databases to illustrate what challenges and so forth exist in the practice of rheumatology. And then, of course, education and research have an enormous overlap. Most of the research really in the labs is done by trainees, by fellows, by postdocs, by volunteers, by students, and so forth. And so education happens in the lab, and what we do in the lab serves our educational purposes very nicely as well. And in this Venn diagram, I would put the trainees, particularly our fellows and postdocs, at the very overlap of these three areas. And our T32 training grant supports that center of gravity for us. And I often put well-being as part of our educational activities. So I'm going to tell you briefly about where we are in these three different realms. So first, our clinical service, which we less seriously often call our room service. Just like a five-star hotel, we have our room service. It is carried out by about 14 or so clinical faculty whose predominant role is to see patients, and with a great deal of flank support from four clinician scholars, five physician scientists, and also we are very happy to have three of our emeritus professors still clinically active. They are incredibly valuable. They have a long record and memory of the rarest rheumatic diseases, and can bring cases and knowledge and wisdom to all of us, including, of course, our fellows who learn from them many of the tricks of the trade. We also have a number of teaching associates, nurse practitioners. I think there are three at this moment. We have a steady state of four, but three at the moment. And then let's not forget the fellows. They contribute very substantially to our clinical work, seeing patients. We have four fellows per year, so a steady state of eight, plus typically at least one fellow who stay for a third year, usually on the physician scientist track. Now, rheumatology has a great deal of overlap with many other specialties. Rheumatic diseases can affect the lung or muscles or the skin or the eye or other organ systems. And we have a, I think, very productive and appreciated collaboration with pulmonology in our interstitial lung disease clinic. We work with neurology in our myositis clinic, with dermatology in our rheum derm clinic, and at the VA we have a very productive overlap with ophthalmology in our rheumatology uveitis clinic. And then I would be remiss if I didn't mention we work very closely in all our aspects with the pediatric rheumatology group in the Department of Pediatrics. And so we are mindful of making it easier for young patients who go to a pediatric rheumatologist to transition over to an adult rheumatologist. That's an important transition for patients and for us. We used to have a clinic with nephrology particularly for lupus nephritis. And actually I would be, and I believe Raj would be very supportive of restarting that kind of clinic again. Our division has a long history of working with indigenous populations in the Pacific Northwest. We have traditionally visited them on a regular basis. We call it our tribal clinics in many different areas. We still have, particularly Ingeborg Saxon and Greg Gardner are still doing a regular tribal clinics in, I think, 3 different areas in the state today. And we bring fellows there who are eager to learn and see how to serve indigenous patients. I'm going to mention that a little bit in a moment again. 2 special things we have in our division that sets us apart from other divisions of rheumatology elsewhere. One of them is a giant cell arteritis. So this is a relatively rare but potentially catastrophic rheumatic disease where a sudden inflammation of an artery can cause very serious emergency situations. For example, if the artery behind the eye is suddenly attacked, sudden blindness can result if giant cell arteritis patients aren't given quickly the required expert attention. So our giant cell GCA fast track clinic consists of a phone service available for all physicians to call us and get their patient in within 48 hours, if not 24. Then we have put a lot of emphasis on the use of ultrasound for rheumatic diseases, and we've trained fellows in it, and we have international connections. We actually organize an annual meeting to teach ultrasound use to an international audience, and it's a very valuable exchange with others who have their own experiences in ultrasound use. It's a non-invasive approach to diagnose arteritis and other similar conditions in arteries and as well as joints and tendons around joints. So our clinical work is predominantly outpatient work. We have a little bit of inpatient service, takes more time than it produces work RVUs, but of course critically important as well. So outpatient clinics we have at the Roosevelt Clinic, just a couple blocks from the main campus, at the Arthritis Clinic at Northwest Hospital, at Harborview Clinic, and of course at the VA, all very important. The inpatient service that we do in rheumatology is to a large extent at Montlake in the main hospital, but also some at Harborview, a little bit at Northwest Hospital, largely by phone, and of course at the VA. So about 2 years ago, we were discussing in our offsite retreat how to value and reward faculty, particularly those who put their heart and soul into clinical work and teaching our fellows. And we decided to institute an annual prize. So the Gregory Gardner Outstanding Faculty Award is named for Greg Gardner, who is still with us as an emerita professor, but really is a living legend who contributed to the division for over multiple decades. And for example, is the originator of what we call the Gardner Rules. So fellows learn the 50 Gardner Rules in rheumatology, many very light-hearted and easy to memorize, and sort of forming a legend in rheumatology. And we decided that a good way to handle this prize was to give the emeritus professors the task of ruminating and evaluating and deciding who each year would receive this, we believe, very prestigious prize. So in our offsite retreat just earlier this year, the emeritus professors, in their infinite wisdom, decided to award the prize to Mark Wenner. Last year it was Grant Hughes, and you can see we have empty plaques for multiple awards in all the coming years. A fun tradition, I think. So a few words about our educational activities. We provide education in multiple different forums. The flagship really is our Rheumatology Fellowship Program, which I will talk about a little bit more in a moment, with all the aspects that come with the fellowship program. We do also engage internal medicine residents, medical students, visiting students. We are very happy to provide rotations in rheumatology and to welcome into our clinic or into our laboratories anybody with aspirations of a medical career to learn and follow and talk to us. We also have a group of postdocs, some of them MDs, some of them PhDs. Of course, we have a training grant that can support some of them as well as some of fellows. We also bring mentorship for all our junior faculty and actually for all our faculty. Just as an example, I have two mentors that have been very helpful in my role as a division head. And we engage in the new training of our mentors to make sure our mentorship is of high quality. I mentioned already we teach ultrasound, not just internally, but internationally. Of course, we do continuing medical education all of ourselves, and we have multiple principal talks and seminars. We have a ground round series in rheumatology. We have one of them is our dedicated Lane lecture, which I will mention a little bit more in a moment, and then other smaller invited lectures and seminars to bring the wisdom that people have outside of UW to us here within the U. And I would be remiss if I didn't mention that we are quite active, many of us, in the American College of Rheumatologists meetings, planning meetings, and many committees, including those that have to do with educational activities in rheumatology nationwide. So the fellowship program, I think we are very proud of. It has been around for a very long time. In fact, it's been around ever since the division was established in 1958, called the Department of Arthritis in the beginning. The current leadership of our Rheumatology Fellowship is directed by Grant Hughes. He's been 10 years in the director position for the fellowship program and has, with his team, done an absolutely outstanding job in bringing our fellowship to a great national, if not international, reputation. Just as an example, we have way over 200 applicants every year that we try to select the very best from. The program has two associate directors, Jenna as a role model for a clinician scholar and educator, and Namrata Singh, who is a fantastic role model for a research career in rheumatology. And all the real work, all the heavy lifting is done by Tiffany Wallace, who is absolutely outstanding in that role. So our fellowship program is, like I said, one of the oldest in the nation. We have a very long-standing T32 grant. We are just waiting for the notice of award for year 45, and we just are in the process of finalizing the submission for the next 5 years, so years 46 to 50, half a century of training. And at this point, we have trained about 120 rheumatologists, some of whom have gone on to very illustrious careers division heads and full professors and so forth, many of whom have moved the field of rheumatology forward in a more substantial manner. So, of course, the purpose of the fellowship program is to make excellent rheumatologists from diverse backgrounds. We have put quite a bit of emphasis on diversity in the many last years. Not just that, the fellows really are the Duracell bunny batteries in the division, it feels like. They inject energy, they keep us on our toes, they keep us sharp, and they make a lot of activities a lot more fun, both in the clinic and in free time and in educational activities and so forth. And I think I mentioned already, fellows do a very substantial amount of clinical work, so our patients benefit majorly from the fellowship program. And fellows are really important in our research enterprise. They all carry out scholarly projects, either small or larger, and a number of them get engaged long-term in their career in research as well. So in the end, the fellowship program really is our number one source for new faculty. We sometimes tongue-in-cheek refer to it as our 2-year interview process. So the endowed lecture I'd like to mention because it's something we are very happy with. So James Lane was the first fellow in our program. And a few decades later, the Lane family decided to endow a lecture series, which we are happy to carry out every year to honor Dr. James Lane and his accomplishments over the years. We were fortunate to have him with us in person during the Lane lectures until last year. Dr. Lane sadly passed away. So just last month, we had the Lane lecture for 2025. And we always use this opportunity to invite some really prominent, influential rheumatologists, scientists, to speak to us about the latest and greatest ideas and approaches in rheumatology. So this year we had Georg Schett from Germany as our Lane lecture speaker, and he did an outstanding job. And I will tell you briefly what he did because it's truly remarkable and paradigm shifting in rheumatology. So Dr. Schett has applied CAR-T therapy to rheumatology and really pioneered its use in rheumatology. So for anybody out there in oncology, you are probably familiar with CAR-T therapy. So this is a cell-based therapy in which leukocytes are taken out of a patient initially for the first 8 years of the life of these therapies. These were patients with B-cell malignancies. And then the T cells were purified, enriched, and then transfected with a chimeric antigen receptor, which is a engineered version of the T cell antigen receptor in which a little bit more of the signaling domains have been grafted into the receptor. And then the extracellular piece has been replaced with an antibody, a part of an antibody that's highly specific for the CD19 molecule, which is only expressed on B cells and is present on all B cells. So these cells are then expanded and they are given back to the patient, where the T cells now will be activated by every encounter with a B cell, resulting in the killing of those B cells. Now, in a patient with a B-cell malignancy, that results in many cases, over 30% of all patients are totally cured because all the malignant B cells are killed off. The T cells will linger enough time to find every single B cell. So in the field of rheumatology, Dr. Schett and his team used this for initially a single patient, compassionate use, a young girl, 6 years of age, with a very severe case of lupus, with really a bleak prognosis for her future. This is that girl about 10 years later on, she has been completely cured of her lupus. And so Dr. Schett described in great detail about 40 patients that they have treated in Germany with CAR Ts in 39 cases of 40, completely cure the patients with lupus. Patient number 40 had a brief relapse and had to be retreated and had developed neutralizing antibodies, which is why this patient wasn't cured. And eventually was treated with a different CAR T against B cells. And then after that, was entirely back to a normal. So this is truly remarkable. Lupus has not been cured ever before. And now 40 patients of Dr. Schett's have been transformed into a state where they have no autoantibodies, no signs of immune activity, nothing at all that would reveal that they had lupus previously in their life. And I'll come back to this briefly in the end of my talk to give you another view of why we think this works so remarkably well. Just another example of our educational activities. This is a slide from a lecture we gave to the allergy group in the Allergy and Infectious Disease division. We have a shared interest with the allergists. They are interested in the eosinophilic granulocyte because it is a key cell in the eosinophilic form of asthma and potentially other diseases as well. In rheumatology, the eosinophil is responsible for one subtype of ankylosing, so a disease in which eosinophil activation causes granulomas and inflammation around arteries in many different organs, sometimes a very severe disease. So that also kind of segues me over to our research enterprise. We have slowly grown our research faculty, and including some early faculty transitioning from fellowship into a early faculty position. We are estimating to be 12 research faculty before the end of this year, which is a nice growth the last few years. Our research fellows vary from year to year. We typically have at least one in either first year or second year fellow or a third year fellow. And that has increased a little bit over the years. But the reason you're not seeing a huge growth in it is that these are the fellows that transition over into faculty and become our research or physician scientist faculty members. So the research fellows are feeding into the research faculty numbers. We have also, because of more faculty, more grant support, we have also been growing the number of postdocs in the lab, which I'm also very happy about. We essentially have a postdoc community within the division, which hopefully we can grow further in coming years. Just to give you some evidence, here our research faculty. Our research faculty focus on different areas, some more basic research, some very clinically oriented research, and everything in between. Most of us have an eye to patients and want to do research that benefits directly or indirectly clinical service of our patients. For example, trying to understand the molecular mechanisms of rheumatic diseases. Here's the early career researchers who may well be among our faculty in future years. So our research, I believe, has a long list of accomplishments. We have, since 1958, made many contributions to the field that have been noted and by others and taken up and contributed to the shaping not only of the understanding of diseases, but also treatment of patients. So the current paradigm for rheumatoid arthritis treatment with a more remission-inducing regimen up front and then tapering off as needed and titrating the treatment is really a concept that came from our university, our division. In the early days, a lot of work on immune complexes, understanding how the immune system contributes to lupus and rheumatoid arthritis through a multitude of mechanisms, including complement activation on circulating immune complexes, which in turn can drive more inflammation. I mentioned our interest and engagement in indigenous populations, our tribal clinics. That was not only clinical service in the past, but also a great deal of research. And our faculty documented the skewing in prevalence of a number of diseases and was very interested in understanding why that was. And so rheumatoid arthritis, for example, is clearly of a higher prevalence in native populations, as is lupus and other diseases. And at least a partial explanation for it resides within the MHC complex and different frequencies of certain alleles like HLA-DR4, which is one of the risk alleles for rheumatoid arthritis. We've done some other things. I would mention Keith Elkon's longstanding work in lupus, and particularly the involvement of type 1 interferons in lupus, which is a very interesting biology because the physiological role of type 1 interferons are in infectious disease, particularly in the immune response against viruses. And in the end, then, the role and importance of type 1 interferon in lupus demonstrated very nicely by anifrolumab, a blocking antibody for the type 1 interferon receptor, sort of as evidence that interferons really are important in driving disease. Makes the disease look a bit like chronic viral infection, which has been a starting point for my own research and others on our research team. And we've done some interesting things in the last few years. So just to show you some examples, the ultrasound that I mentioned earlier, we have published our fast track clinic and some of the principles for it. This is a quite well cited article out there. Here's another, I think, important discovery in rheumatoid arthritis. Here's something I'm going to talk a little bit more about in a moment. Here's some more clinical trial-related research. Here's some genetic discoveries from Jim Jarvis. Here's another clinical trial-related study in rheumatoid arthritis, what may correlate with efficacy to a certain drug that's used commonly. And here's an example of one of Namrata Singh's studies on rheumatoid arthritis and the medication, and looking at outcomes in different patient populations. So I'm going to spend the last 20 or so minutes with just as an example of research, something I'm really, really excited about, because I feel that this discovery is the opening salvo to perhaps even rewriting the whole paradigm of what autoimmune disease really is at the molecular core. So this is a story that started with Rayan Najjar coming to our division as a fellow a few years ago. He came to my lab in his second fellowship year and stayed throughout the third year, supported by the T32 grant. Rayan is a very unusual guy in that his background not only is an interest in rheumatology, but he has a long background in statistics, in computer programming, and in the analysis of large data sets. So he came to my lab saying he would like to learn and implement computational aspects of large data sets to understand rheumatic diseases better. And we sort of learned together what tools and approaches and questions can be addressed by the newer methods that exist nowadays in the realm that many people still call bioinformatics, although I think computational biology is probably a better term. So one day, Rayan asked me if it would be okay if he tests out software for mRNA splicing prediction. And I said, sure. I don't think anybody's done that before in lupus, so who knows what we might find. What we discovered really blew all of us away completely. So it turns out that in lupus, and neutrophils are the cells we typically work for. I could separately explain why we chose neutrophils, but I think it's a very interesting cell type and starting point. And there's quite a bit of recent data suggesting that neutrophils are important in lupus. So we generated over the last few years a good-sized data set, RNA sequencing from 35 lupus patients, from 20 healthy donors, and from 15 rheumatoid arthritis patients. And Rayan, who is now an assistant professor on a K Award and has two postdocs working with him, engaged in further analysis of the mRNA splicing that I mentioned. And so Ning Wang in his lab is helping with this work. So at this point, of the 35 patients, 34 at least have serious errors in mRNA splicing. And what excites me the most are the splicing events that we call cryptic. So cryptic splicing means splicing events that occur only in lupus and have never been seen before in any setting, including in any of our healthy controls or rheumatoid arthritis patients. So these are truly lupus-specific and abnormal splicing events. And I'll show you in a moment what some of them look like. So in 35 patients, we see a total of 181 of these abnormal events in a total of 46 genes. So here I'm showing you how many of these events and genes affected there are in each patient. And you can see some of them, some patients have a lot of them. So the top there is about almost 20 different genes and almost 50 different abnormal splicing events. And these are all with read counts that are substantial, meaning they are not just random errors, they are truly recurring mistakes. And then patients have, a decreasing number. There are some patients who have very few of them, but all but one of the patients at the time of blood draw had such errors in splicing. So what makes me really interested in all of this is that a good number, not all of them, but a good number of these abnormal splicing events, when Rayan predicts what their translation products would look like, they include completely novel amino acid sequences. And so that's quite remarkable. So here's a snapshot of what the genes are. And you can see there are definitely a number of genes that these events occur in more frequently. And interestingly enough, those are all interferon-inducible genes. And I told you earlier that lupus is characterized by elevated type 1 interferon. So that clearly plays some role in these mRNA splicing mistakes that happen. So we've been spending the last couple of years trying to validate all of this and see if it really is occurring, if it's only computational, or if it really results in things that are consequences of the mRNA splicing. So what I'm showing you on this slide is work that Xiaoxing Wang in the lab did. She immunoprecipitated HLA, so class 1 MHC, from a number of patients who you can see here in the second column. And then we eluded all the peptides bound to HLA and analyzed it by mass spectrometry, LC-MS-MS. And you can see we found 24 of the peptides predicted to result from the abnormal splicing events. And so we have the same patients whose RNA we sequenced. And so we knew who should have what antigen. And here's evidence that these neo-sequences not only exist, but they are translated and they are then processed and presented on MHC, of course, in parallel with all the self-peptides that normally exist on class 1. And also quite remarkably, when we used the software prediction for affinity of binding to the type of class 1 MHC that each patient has, which you can see in the second last allele, almost all of them are also predicted to bind with very high affinity. There really is only one exception on the list, one that is predicted to bind with the intermediate affinity. That sounds kind of right. So the splice events, when you look more closely at them, what are these abnormal events that result in novel amino acid sequences? And so let me just explain to you what I mean by a novel amino acid sequence. I mean an amino acid sequence predicted to be translated from the mRNA that if you do a blast search against all known non-redundant proteins, you find 0 hits. There is nothing in the known database that has exactly the sequence of these novel sequences. So in the first example here is a very simple event. It's the aberrant skipping of one exon in a gene, in the ABCG1 gene. So because this exon is not meant to be skipped, the number of nucleotides in it is not divisible exactly with 3, meaning that if the transcript lacking exon 9 is translated, exon 10 will be translated in a different reading frame and therefore give rise to an entirely different sequence. And this theme is present in many of the abnormal splicing events in lupus. So sometimes it's a skip of 2 exons that puts the reading frame out. Sometimes, like in the USP18 gene, it's an elimination of 4 exons in a row. That doesn't normally happen, I think, ever in a gene that 4 exons would be skipped. So when they are, exon 11 in this case is read in a different reading frame, and so now there's a stop codon in it. So the protein that is made is probably fine until its C-terminal tail that is truncated and completely novel. The other theme that you can see 2 examples of here is where an intron is not excised as it should be, but a piece of the intron is spliced into the final transcript and is then translated, resulting in a completely novel little sequence. And oftentimes that little intron piece is a retrotransposable element, such as a line 1 or an ALU element, which are in fact abundant in many of our introns. So the real question that we wanted to address then, and this is an experiment just done a couple of weeks ago by Farine Sheikh, who is a postdoc in the lab, and Ethan, who is helping her out with all the work in the lab. So the question is, do these neopeptides now presented on MHC, are they truly seen by the immune system as foreign peptides, as something that the immune system should recognize and respond to? And the answer appears to be yes. So Farine and Ethan took PBMC from a lupus patient. They incubated them for 14 days with mixtures of peptides taken from these neo-sequences. During these 14 days, any T cell that can recognize any of these peptides presented on MHC will be activated and expand so that after 14 days, there's more of them than there would have been by random chance in the beginning. And then after 14 days, we add the peptides back, and typically one peptide at a time, to see if any of the T cells then quickly get activated and produce cytokines. And because the ELI spots are a little bit hard to see, I have a graph here. So what you can see is that the positive control in which we stimulate broadly T cells, we get multiple colonies of T cells activated producing interferon gamma. But so do many of the other peptides, the peptides that come from neoantigens. So we selected a number of peptides. They are 15 amino acids long, which is a bit longer than MHC presentation, so they can choose how they bind and be trimmed. And clearly, many of these peptides had expanded T cells and now acutely reactivate those T cells to make interferon gamma. So this is pretty strong evidence that there are T cells in our lupus patients, or in this lupus patient in particular, who have seen before and can react and get activated by these neopeptides derived by abnormal splicing of several genes. We took it to the next step. These are now assays asking if the patients also have autoantibodies that have been class switched into IgG and have a decent affinity, recognizing epitopes within the neo sequence. So what we've done is generate 15 amino acid long peptides that cover in a tiled fashion the neo sequence. So here, for example, the long neo sequence in the MX1 gene is made of 6 different peptides that overlap each other so that we don't miss any epitopes. And the ELISA assays were done by Xiaoxing Wang in the lab, and Cecilia, who is my daughter, and is an unpaid volunteer in the lab. What the two of them saw was actually quite remarkable. So yes, the answer is yes. Many lupus patients do have autoantibodies that recognize epitopes within the neopeptide sequences, which really means that these peptides have not only been seen by T cells, they have been seen by B cells, and the T cells have provided help to the B cells who have class switched and probably affinity matured and made some pretty strong antibodies, which is, I believe, very strong evidence that these neo sequences have been present in our lupus patients for a long time, maybe months, probably years, and they have mounted a slowly escalating immune response, which is a completely novel and I think very, very exciting discovery. So this all comes together in a brand new hypothesis for lupus pathogenesis. So besides type 1 interferons being important, we now propose that neoantigens made in the patient by aberrant mRNA splicing, possibly by other mechanisms, but certainly by aberrant mRNA splicing, resulting in peptide sequences that the patient did not have in his or her, usually her, youth, and therefore do not have immunological tolerance for, and will see if they show up later in life as foreign antigen to drive a strong immune response. So we believe that the immune response against these neoantigens, then under the influence of interferons, would look very similar to what an antiviral immune response looks like, which we and others have published and shown is the case. So it then stands to reason to hypothesize that these neoantigens also provide the cause for exacerbations. So maybe if the splicing goes wrong for an unknown set of reasons at a point in time, that's when the disease flares. And if the splicing is returning back to somewhat more normal, then the flare will subside and the patient may go into remission. That's one of the hallmarks of lupus. It comes and goes with exacerbations and remission. So this now, I think, also fits beautifully in with Dr. Schett's CD19 CAR T findings. So here, what he showed was that in order to cure a lupus patient, they have to completely eliminate every B cell in the patient. The therapy effect lasts for about 100 days. Then slowly but surely the B cells begin to come back. But now they come back as completely naive B cells who have just gone through the whole education of tolerance. And if there are neoantigens present, they are now tolerant to all of those neoantigens. So the re-emerging B cell compartment is completely tolerized against all the neoantigens that have been present during that time. And therefore, they do not react and they do not present antigens to the T cells, and the patient has no signs or symptoms of lupus anymore. Fits with our hypothesis very, very nicely. So now we just have the really big job ahead of us of figuring out why mRNA splicing goes wrong. And I can tell you that mRNA splicing is an incredibly complex process, involves more than 200 mRNA binding proteins. People in the field of oncology have a great interest in mRNA splicing because neoantigens that fuel anti-tumor immunity is largely dependent on neoantigens made by mRNA splicing. So we essentially tell our hypothesis says that lupus has that in common with malignancies. The dysregulation of mRNA splicing resulting in neoantigen and an immune response against it. So if this is all true, which of course remains to be proven and convinced to the rest of the scientific community, SLE would simply be a disease of neoantigen production by mRNA splicing plus the influence of type 1 interferons. I did mention that many of the genes that result in neoantigens are interferon-inducible genes. So this all kind of ties together surprisingly nicely. My good friend and collaborator, Felipe Andrade at Johns Hopkins, and I put all this together as a hypothesis, which we published some time ago. We call it the neoantigen hypothesis of autoimmunity. And we believe it might be applicable more broadly in diseases beyond lupus. So I'm just going to finish by saying that there is still plenty of unresolved mysteries, big questions in the field of rheumatology. We do not very well understand the cause and exact pathogenesis of many of the rheumatic diseases that we are treating in our patients. The future is open for possibilities. Lots to do. We have job security for at least a century or more in the field of rheumatology research. So I'm going to stop there and acknowledge everybody in the lab and the funding sources and all my collaborators, and thank you for your attention. And I believe we have about 7 minutes or so for questions.
Thanks, Dr. Mustelin, for such a fascinating overview of the division and the future of rheumatology. If anybody has questions, please put them in the chat and we will bring them forward. Maybe I can just start off, Thomas. So you've demonstrated the neoantigen hypothesis in lupus. Lupus is obviously a very heterogeneous disease. How do you think that the neoantigen hypothesis would play into the heterogeneity of lupus?
Yeah, that's a really great question. So I think not just lupus, but a couple of other diseases that have very similar features like inflammatory myositis and Sjögren's syndrome are all examples of where it matters where the neoantigens are made. So we just looked at neutrophils so far, but we do know that in myositis there's also some problems with mRNA splicing in the muscle cells. So one easily imagined source of heterogeneity would be, number one, in what cell type is mRNA splicing going wrong and resulting in neoantigens? Because the genes don't really matter. It's just the cell that makes the neoantigens that matter for where neoantigens will be presented and where the immune system will direct its attention. And so I think in Sjögren's syndrome, a likely scenario would be that it's the salivary and lacrimal gland cells that make neoantigens. And in myositis, it would be muscle. And in skin lupus, maybe it's more keratinocytes that generate such neoantigens. And then we don't really know the biology that drives the altered splicing, but you could imagine that it comes and goes in different cells and different tissues, driven by viral infections and stress and UV light and many other potential factors that we know patients often get an exacerbation from.
Thanks. So a question from the chat. Do you think EBV may be important in initiating cryptic splicing?
Yeah, that's a really great question. So EBV has risen up in the last couple of years as a real culprit of autoimmune disease. I think the answer is probably yes, and I think EBV is not alone. I think other viruses, cytomegalovirus being another great example. These viruses are difficult for the immune system to eradicate, so they linger and they present many different immune evading mechanisms. So they promote a should I say, a low-grade immune activation that lasts for a long time, and they interfere with processes, potentially also mRNA splicing, and likely function as triggers of let's say promoting the breakthrough into clinical prominence of pathology that might have been going on previously in the individual person who subsequently gets the diagnosis of lupus or rheumatoid arthritis or another autoimmune condition.
And another question from the chat. Can you expand on the mechanism underlying aberrant RNA splicing in lupus, and is the defect specific to neutrophils?
Yeah, those are both good questions. So looking in more detail at all the splicing events, there are certain patterns, and I've consulted a number of colleagues out there who focus on mRNA splicing for their career, with the question of if the pattern gives any hints to what splice factor or what mechanism would be involved. And by and large, they shake their head and say mRNA splicing is so complex that nobody can really go from the pattern of splicing to predict which factors are altered. But I can tell you there are a couple of hints. One of them is the inclusion of intronic sequences hints to a small group of mRNA binding proteins whose job it is to bind intronic sequences, including retrotransposon sequences, and prevent them from being spliced. So they're like do not splice here factors. And so any deficiency or lack of any of them would be predicted to result in these little intron pieces being spliced in aberrantly. So, and I can also tell you that in neutrophils from lupus patients compared to healthy controls and rheumatoid arthritis patients, some splice factors and mRNA binding proteins are statistically significantly expressed lower or higher, which might indicate that they do not work fully as they are supposed to do. So the last question about other cell types, the only thing we have at this point is we have seen some mRNA splicing problems in muscle in myositis, but we are, of course, eager to find other immune cell data sets, and we are looking at generating some ourselves to ask if it happens in other immune cells too.
Thanks so much. I think we're pretty much at time, so we'll conclude this grand rounds, but I really appreciate, Dr. Mustelin, your thoughts and educating us all about rheumatology and the advances in rheumatology. Thank you very much.
Thanks, Cynthia. And if anybody wants to contact me afterwards with more questions, that'd be great.
Thank you.
Thanks.